What has been exciting, despite the very grim prognosis in stage 4 pancreatic cancer, that with bringing on board 2 new modalities in the frontline settings that are standard of care, we have now even had a second line or post-gemcitabine standard of care treatment. The nano-liposomal irinotecan is an FDA approved for post-gemcitabine advanced pancreatic cancer, metastatic or not, in combination with 5-FU and leucovorin. This is the only FDA-approved drug in that setting. It's a category level 1 in the NCCN guidelines. It's a great opportunity. We have really moved from 5 years ago thinking about advanced pancreatic cancers. For when it comes to systemic therapy, we have one shot at this disease, to start thinking there is a first line, there is second line, and we have many clinical trials even looking beyond second line. We're moving a bit pancreatic cancer to maybe join the club of the colorectal cancer and the lung cancer and maybe breast cancer. We're not quite there in the efficacy, but we're moving the needle as well. This is crucial, and it's important to discuss with the patients about these options. There is data showing about what's the percentage of patients who made it to beyond second line in pancreatic cancer. About 10 years ago, that number doubled in recent days. In part, it's because of the advance of supportive care as well. I give credit for that. Maybe earlier diagnosis with aggressive management with the newer drugs that are and regimen that are on board. So this is crucial to really think about it like a chess game, like we always say. Don't just think about the immediate move or immediate line of therapy, but what would be subsequently. Having the option of using the nab-paclitaxel regimen, nano-liposomal irinotecan post-gemcitabine, personally sway me more to use gemcitabine-based regimen in the frontline setting.
We never, ever thought we'd be thinking about second-line pancreas cancer. And now, frankly, we're thinking about third-line pancreas cancer in some patients. Now, it's interesting, different places have different feelings about this. In some more rural, maybe less well-educated populations, people show up being pretty sick to start with. And so they often don't make it into second or third line. But the majority of patients now are of a good enough performance status, the diagnosis has been made early enough to where we can think about lines of therapy, just like we did with colorectal cancer, where we said it mattered to get all the medicines. We don't have a biomarker to tell you which one to take or which one not to take, so I want to try them all. So now I'm thinking about sequential therapy, and you really have 2 strategies you can go with. You can go with 5-FU-based regimen, that would be FOLFIRINOX typically, first line, or gem-based first line. But either way you go, you can then go to subsequent lines of therapy. Newer approvals with 5-FU-based therapy in second line and beyond have really shifted my way of thinking, is to initiate with gem-based therapy first and then use 5-FU-based therapy second. But that's not hard and fast. In different patients, we make different decisions. But in general, I'm thinking sequential therapy. I want to give gem-based therapy. I want to give 5-FU-based therapy, usually in that order.